Good evening, viewers. My name is Rahul Desai, and on behalf of FDC and MedTalks, I hereby welcome you all to today's fifth important module in our journey of Diabetes Essentials 52 Weeks, Dr. Sanjay Kalra sir. Dear viewers, these online modules are an educational initiative from Enerzal Zero and in memory of late Dr. K.K. Agarwal sir. Last episode, Dr. Kalra took us through meeting laboratory and physical targets in diabetes, which was a very important topic. And connecting today, we have another important topic that is comprehensive medical evaluation and assessment of comorbidities. Dear viewers, today's module will help us to understand the confirmation of diagnosis, evaluation of diabetes complications and potential comorbid conditions, patient engagement in the formulation of diabetes care management plan, as well as ongoing management, which should be guided by the assessment of overall health status, diabetic complications, cardiovascular risk, hypoglycemia risk, and shared decision making to set the therapeutic goals. So, before I hand over the platform to Dr. Kalra sir to take us to today's important module, let me have the opportunity to announce the names of those doctors who have answered the quiz questions correctly from the last episode. And the names are from Bihar, Dr. Vishal Shekhar. From Delhi, we have Dr. Umesh Kumar Malhotra. From Gujarat, we have Dr. Bharat Pravin Mittakola, Dr. Dhirendra Sanandia. From Karnataka, we have Dr. Ajit Hegde, Dr. Ramesh Hegde, and Dr. Satish Jain. From Madhya Pradesh, we have Dr. Shashi Khare. From Odisha, we have Dr. Gangadhar Rath. From Punjab, we have Dr. R.L. Taneja, Dr. Namrata Puri, Dr. Sanjeev Puri. From Maharashtra, we have Dr. Anand Purandre, Dr. Dharmika Tandon, Dr. Girish Gesota, Dr. Vishal Mutkule, Dr. Hitesh Vora, Dr. Kulbhushan Tandon, Dr. Suresh Pawar. From Uttar Pradesh, we have Dr. Ambarish Chaudhary, Dr. Ashwini Kumar, Dr. Surjit Kalsi. And from West Bengal, we have Dr. Santanu Kumar Bhattacharya. So, congratulations to the doctors. And with this, one more reminder to the viewers on 15th April, we had the biggest event of this financial year with Dr. Vivian Fonseca addressed the audience on scientific approach in improving the vascular and metabolic health in diabetes. Any of the viewers who want to revisit the session again or who have missed to go through the session can view the session on the same platform. With this, I hand over the platform to Dr. Kalra sir. Sir, over to you.
Thank you, Rahul, and good evening, everybody. Welcome back to our Sunday show of Diabetes Essentials. Each Sunday, we talk about different aspects of diabetes. And the beauty is that even after 1 year plus, there is so much to speak about, so much to talk about, so much to learn. Today, let's talk about glycemic goals and how we can do a medical evaluation and assessment. We'll talk about specific things in diabetes care, things that we sometimes miss. You must have seen that we keep on speaking about the same philosophy again and again. The reason is that it is this philosophy, a very inclusive, a very involved, a very team oriented philosophy of diabetes care, where the patient, the person living with diabetes, is at the center of everything that we do. Our aim, we must remember in diabetes care, is to keep our patient happy and healthy. If our patient is happy and healthy, we ourselves will become happy and healthy. So let's focus upon this slide today. This slide says a lot to us. This is the decision cycle for patient-centered glycemic management in type 2 diabetes. Let us dissect this sentence. We are focusing on type 2 diabetes, but we can also include type 1 diabetes, pancreatic GDM in this. We are speaking of glycemic management, but the same rules will follow for overall management, comprehensive metabolic management. The key is patient-centered, person-centered, human-centered. Remember that the person in front of you is a human, and you have to focus on the human. Now note the first part of this phrase, decision cycle. It is a cycle. It is ongoing. It is self-perpetuated. It is not a single line. It does not have a beginning. It does not have an end. It is continuous, like a bicycle, like a cycle. And a bicycle is stable if both of the wheels work along with each other in tandem. Similarly, in diabetes management, if both the doctor and the patient work together towards one goal, then you achieve success. What are the goals of care? Now, this is what the ADS says: prevent complications, optimize quality of life. Maybe we would want to rephrase this and put it first as optimize quality of life, resolve all the symptoms, alleviate all the signs, ensure that the numbers are good. In quality of life, focus not only on biomedical issues like symptoms, signs, and laboratory numbers, also on psychological and social health. So, biological, psychological, and social quality of health. And when you have done this, if you have time, then you also prevent complications or you manage them. So, these are the goals of care. How do we do it? First of all, we assess the patient characteristics, current lifestyle, comorbidities, concomitant medication, clinical characteristics, the type of diabetes. Be careful about psychological and social issues, about cultural and economic issues. So, assess all these. And how do we remember to assess all these? What I do is biomedical, psychological, social. In biomedical, I ask for acute complaints, any symptoms, any skin symptoms, any head, ear, nose, throat symptoms, any chest or respiratory symptoms, abdominal symptoms, lower limb symptoms, maybe sexual symptoms. That is how I go through my checklist. Then psychological and social. Is all well at home? Are you happy? Do you wake up happy in the morning? Do you sleep happy at night? These simple questions asked in a very empathic manner will encourage your patient to open up and to reveal important aspects. Now, once you have assessed, then you have to consider specific factors that impact choice of therapy. What is the threshold that we are starting from? What is the target that we are aiming at? How much complexity can the patient handle in terms of medication? Will the patient be able to take 4 injections a day? Will the patient be able to take tablets at 4 different times of the day? While you assess, you answer these questions as well. And then you choose the appropriate regimen, which will not only achieve correct numbers, but will also promote adherence and persistence to therapy. India is not a very rich country, though many Indians are quite rich. So look at your patient and see how much the patient is able to spend, is willing to spend on healthcare. Now we have assessed our patient for current lifestyle, comorbidities, clinical characteristics. We have been careful about psychology and sociology. We have also looked at the cultural and cost aspects. We then considered specific factors. We looked at the threshold. We moved from threshold to target. And now we want to assess what tools, what techniques are suited to the patient, what kind of complexity the patient can handle, what kind of potential side effects there are for different therapies. Now you have a fair idea of what to do. So now we come to shared decision making. So you tell your patient, inform your patient. So my language might be as follows for a particular patient. Madam, according to these glucose numbers, you need insulin. The textbook says that you need insulin. If you're comfortable, let's begin. If you're not, will you be able to follow the lifestyle modification that I'm going to advise? Will you be able to follow a strict diet? Will you be able to stop alcohol? So you ask these questions, let the patient speak, listen to the patient's preferences, and then give the proper therapy. You have to share the decision making. I also get irritated sometimes at my patients when they don't accept insulin. But you should try to suppress that irritation and anger, and you should try to counsel them properly. So sometimes it does get irritating when they say that, such and such an alternative care professional or my maid servant or the hawker on the road said that you should not take insulin. You should go to the faith healer and take desi medicine from him. That does irritate, but try to handle it in a non-judgmental and in a soft manner. Now, whenever you're speaking with your patient, you should have a target in mind. And the targets should be smart, specific, measurable, achievable, realistic, and time limited. So it might be by next time you will feel much better. You will begin to feel hungry. Sir, there will be a smile on your face. I'm sure you'll be happier than before. Now, these are all soft, subjective kind of goals, but they are important. These will lead on to objective goals. Your glucose will have come down by 50 milligram fasting and 100 milligram postprandial. Your lipids will have come down in 6 weeks. So you might say something like the anabolic effects of insulin will be seen within 3 days. The postprandial glucose will come down within a week. The fasting glucose will come down within 10 days. And the HbA1c, lipid profile, liver enzymes, we will check after 3 months. So you have to agree upon the management plan. Then you begin implementing. So then you focus on diet and exercise and you see how frequently would you like to come. Now, this question is important because the patient decides. Patient may say, I am coming from 300 kilometers away. It is so hot. Temperature is 48 degrees in Rajasthan, where I come from. So I will come only after the rains begin. That's fine. Another patient may say, I just live 2 kilometers away from you. I can visit you next Tuesday. So that is also fine. That is welcome. So you decide that. And if hand holding is required now for the next 3 months, then you figure out how it will be done. Will it be done on phone, on WhatsApp, or through a local doctor? Do remember to focus on emotional well being as well and on tolerability of medication. So there should be some kind of a monitoring device in place. Or you can tell the patient if you're fine, that's good. If you feel uncomfortable, please contact us at this number. Or please show the local person in emergency if the following things occur, whatever they are that you are worried about. Whatever you do, you just review this on an ongoing basis, ensure that there is adherence to therapy, and if required, you call the patient more frequently. If not required, you can call every 3 or 6 months. So for each patient, it will depend on the patient's requirements at that particular point of time, and this cycle will continue forever and ever. At the initial visit, do remember to confirm a diagnosis of diabetes and to classify diabetes. Most of the time, your diagnosis will be very clear. It will be type 2 diabetes. Sometimes it will be very clear type 1 diabetes or gestational diabetes. Other times you may get stuck. So, no harm in telling the patient your pancreas is not working well. There are multiple causes for this. Right now, we need to give insulin, or I'm prescribing a tablet. The situation will unfold. It will become clear in about 6 weeks. As a defense, or just to uh, sort of be diplomatic, you might say, we can get the test done right now, but they will not have an impact on my therapy today. Certainly, after 6 weeks, you will have stabilized. Then we'll get the test done to classify the type of diabetes. So, patient is willing to understand that. You might also wish to gain some brownie points by saying, if we get the test done today, it will be a long list, 10,000 rupees. If we just wait for 6 weeks, the number of tests required will reduce because we will have a fair idea from what has happened to you over the last 6 weeks. So then the cost of investigations will go down markedly. So please bear with us. Please wait with us. So that way you are telling your patient that I am concerned about your economic well-being as well. At the first diagnosis or visit, it is a good idea also to screen for complications, acute and chronic. In chronic, they can be micro or macrovascular, but also viscerometabolic, like obstructive sleep apnea, fatty liver, polycystic ovary syndrome, hypogonadism, dementia. In acute, you can have metabolic, like hypo and hyperglycemia, but you can also have infections, inflammations. So these infections and inflammations should also be screened. In follow up, you follow up on what was the most important thing that you had decided. Patient may say, right now, my main aim is that I just have to control my osmotic symptoms. I don't want to get up at night to go to the bathroom. So focus on that during follow up. And once you have fixed up the acute or immediate needs, then you can move on to felt or long term needs like reducing CV risk. The list of evaluation is long, and many of us will say we are not able to manage this in an Indian OPD. It's difficult. So you can always stagger. You can do it one by one. You do the basics first, like maybe blood pressure and glucose management. In the next visit, you can do maybe lipid management or weight management. You don't have to do everything on day one. Things like vaccination, maybe a hepatitis B vaccine or a pneumococcal vaccine. You don't have to do it on day one. As it is, the cost to the patient will be so high, so you can do it a month later or 2 months later. Talking about psychology, sociology, that is ongoing. Do focus on this in the first visit, but you don't have to do it in detail. You can do it later on as well, one by one. Some tests actually, like TSH, thyroid, and lipid profile, it doesn't matter if you delay by 6 weeks to 12 weeks. Others, it will matter a lot. Maybe a blood urea or serum creatinine or EGFR. So, the most important test from my point of view on day one would be an HbA1c and a renal function test. Serum creatinine is helpful because it helps you calculate EGFR. Blood urea is helpful because the number is bigger, it has a greater impact on the patient. If I tell my patient creatinine has risen from 1.3 to 1.8, that is significant for me. But for the patient's eyes, for the patient's brain, it is not significant. On the other hand, if I tell the patient your urea has risen from 40 to 60, then patient will move, patient will get motivated. So renal function and HbA1c is most important. If it is a patient where you're not very confident, patient is in poor control, then a urine routine is also important. Routine will reveal ketonuria if it is present. It will also reveal albuminuria and the chance of urinary tract infection. So these are the most important. Other tests, like we said, can be staggered over the year, including lipid profile, liver function test. TSH is not mandatory in everybody with type 2 diabetes, but must be done in all those with type 1. In my practice, type 2 diabetes, TSH estimation is done on a clinical basis, I mean, need-based basis. If I feel patient is hypothyroid or hyperthyroid, patient is not responding to therapy in the way I thought, then I get a TSH done. American guidelines say that we should do vitamin B12 in everyone on metformin. In practice, we don't do that. I find it easier and cheaper to prescribe vitamin B12 once a month to all my patients. American guidelines also tell us to check serum potassium in patients on ACE inhibitor, ARB, or diuretics. We don't do that routinely. But if patient is at risk of acute kidney injury or patient is a borderline CKD patient, then maybe it would be a good idea to check electrolytes and urea creatinine at regular intervals. Now, once you have stabilized your patient and you have fixed up all the complaints, the immediate concerns, then you need to go to long-term complication mitigation, to reducing long-term complications. The trick in a busy OPD is you do your triage. You divide your patients into two. Those coming with acute complaints, with symptoms. There you focus just on symptomatic relief. The other group is patients coming without symptoms or with minimal symptoms. Here you focus on chronic health. It's very easy to differentiate between both. If you are confused, then you ask the patient, any acute concern, any burning, overriding concern that you want me to handle first, or can I move on to long term management? And your patient will inform you. In long term management, of course, you look at the heart, the retina, the kidney, and the nerves. So, all four. So, just ask a history. Uh, with experience, you begin to get used to macro and microvascular history. So, again, my language might be any heart disease in the past, any history of breathlessness, easy fatigability, any pain in the legs, any history suggestive of claudication. Have you had a altered sensorium in the past, or maybe a stroke in the past? For microvascular, any kidney disease, swelling feet, anyone ever told you that you have a kidney disease or you had decreased urine output, or maybe protein coming out of the urine? Any altered vision, any signs, symptoms suggestive of neuropathy, positive or negative? Once you've done that, then you ask about hypoglycemia, any symptoms suggestive of hypo in the recent past. Then you examine the patient and then you set a target. Your BP is 145 by 90. It would be nice if it would come down to 130 by 90. Your HbA1c is 12. It's high, but doesn't matter, madam. We'll work together and we'll bring it down to 7. Of course, we can't bring it down to 7 in 1.5 or 3 months. Maybe we can check your HbA1c after 1.5 months. If you're comfortable, it will have come down to maybe 9.5. We will know that we are on the right path. We'll continue the same medication and then we'll check after 3 months. And by that time, we should have reached at least 7.5 or so. So the goal should be set. And then you begin treatment. Do remember in treatment, if you prescribe only drugs, there's not much of a difference between you and a dispensing pharmacist. So apart from drugs, you have to prescribe lifestyle management, sensible sustenance, structured physical activity, substance abuse management, stress management, sleep hygiene. The five S's have to be done. If you find this too daunting, just one positive and one negative advice for your patient. Madam, please avoid taking ghee, butter, and cream. But do focus on green vegetables. Please reduce your TV time by 10 minutes, convert it into walking time. You're already walking, you want to do something more brisk. Why don't you climb the stairs at home? Climb up, climb down, climb up, climb down. You're bored of that? Why not join a badminton or tennis club near you? Or maybe open air gym. In Karnal, our municipal corporation has these beautiful open air gyms in our parks, very beautiful gyms to see. So you can go there, they are very well maintained, and you can do all the aerobics and all the other exercises that otherwise you would have had to go to the gym for. And it's all free of cost. If your municipal corporation doesn't have this, why don't you petition them, ask them for it? If they don't have the funds, just ask for permission to use the park. And why don't you do some crowdfunding? Collect money from your neighborhood and you put up a few swings, a few stationary bicycles, a cross trainer, and you put them up in your park and enjoy health spreading throughout your community. When you're prescribing drugs and lifestyle, you have to monitor as well. So we need to put in place a monitoring plan. How will we monitor glucose? How will we monitor psychological health? Who will monitor? Will we need an extra specialist, maybe a retina surgeon, maybe a diabetes educator, a dietitian? If so, this is how you access them. So these are all things that have to be done. But when you're managing diabetes, be aware of the risk of hypoglycemia. Try to avoid hypoglycemia at all costs, especially in patients with kidney disease, liver disease, old age, long duration of diabetes, dementia, autonomic neuropathy, alcohol use, polypharmacy. In all these patients, you have to be extra careful. So when you're using insulin or insulin secretagogues, make sure that you use in low dose. Teach your patient about hypoglycemia. Ensure that your patient is able to manage hypo himself or herself. Do remind the patient that when you are going on a new insulin regimen or a new secretagogue regimen, it would not be a good idea to go for extreme dieting. Now, there are times when we will not be able to do this ourselves. So you will need help maybe from the gynecologist, from the retina specialist, from a nutritionist, from a dentist as well, maybe from a mental health uh, and ENT, mental health professional and ENT professional. Wherever required, do not hesitate to reach out. And you will be actually pleasantly surprised to see that there will be lots and lots of support in your community. When you reach out to them, when you make them part of the diabetes care team, you will find that you yourself get strengthened. And when your quality of service gets strengthened, the family, the public that you are handling, they get a message that this doctor is very good. The doctor is concerned about my well-being, and they reciprocate by sending more and more patients to you. So that is how a diabetes clinic actually develops. Let's come to our quiz questions for today. Very simple questions this time. And our first question is, the test for checking mean plasma glucose over the previous 10 to 8 weeks is it hemoglobin A1C, oral glucose tolerance test, fructosamine, or fasting glucose? So for the previous 8 to 12 weeks, our choice of glucose monitoring test is HbA1c, GTT, fructosamine, fasting glucose. And our second question, untreated diabetes may result in all of the following except. So untreated diabetes can lead to all except blindness, cardiovascular disease, kidney disease, and tinnitus. Let me repeat the question. It's except untreated diabetes will result in all except blindness, cardiovascular disease, kidney disease, tinnitus. With this, we come to the end of today's talk, and let's take up the questions that we have. Lots and lots of questions coming in, and thank you, Dr. Vinay Desai. Duxab has got lipid profile done, which is quite good. HB1C is 5.7, BMI is 18, really nice, and the cholesterol is 161, HDL 41, LDL 119, slightly high. So, diet, you continue whatever you are doing. Any statin required or any drug required, what we can do, Dr. Vinay, we can do a CV risk assessment for you. Go to Q Risk 3, free website, capital Q, capital R, then risk, small, Q Risk 3. This is a British guideline, British website, and you can put in your data, whatever you have. You also write in ethnicity, Indian, and that will tell you your CV risk. Now, if your CV risk is a bit high, you've not mentioned the age as well. If the CV risk is maybe more than 20% of a cardiovascular event over the next 10 years, then we should take a statin. So the CV risk will decide whether you take a statin or not. How do we initiate premixed in insulin naive if fasting is between 200 and post roughly 200 and PP is 300? We initiate with roughly zero point 0.2 to zero point 0.3 units per kg body weight. So maybe if my patient is, let us say 100 kg, I will start something like 15 units twice a day. Monitor every week. Tell the patient, first your symptoms will improve, you will feel anabolic, you will feel good. Then your postprandial glucose will come down, and fasting glucose may take 10-15 days. Uh, things will improve much faster, but it is good idea to take by the 10-15 minutes days from your patient. Otherwise, patient will argue with you when she comes next time. So we start something like zero point 0.3 units per kg body weight. You can also start 0.2. Average dose for control is 0.44 units per kg per day. This is according to global data. For India, let us remember 0.4 units per kg per day. So if my patient is 100 kg heavy, then average dose of control will be 20 units twice a day. Along with this, we can give metformin. You can also give SGLT2 inhibitor if you want. And if lunch is heavy, you might want to add a tablet at lunchtime, either acarbose or voglibose or repaglinide along with metformin. Dr. Alok Mishra has a clinical case which he wants to share. A patient has alcoholic liver disease and chronic pancreatitis and type 2 diabetes. H1C is 9.7. So he was put on insulin, but there was repeated hypoglycemia because he is not stopping alcohol. What can we do? We should not stop insulin. We can change the regimen. That is first. If patient is getting poor hypo on premixed insulin, actually the treatment of choice is basal bolus, small frequent doses, and the preparation of choice is insulin analogs. The analogs with the lowest risk of hypoglycemia would be fast-acting aspart here, or maybe glulicin. You can also try Lispro for the bolus component, and for the basal component, it would be degludec or glargine 300. But patient may not agree to take small frequent doses, that is 4 doses of insulin a day. Though sometimes you will be able to achieve control with maybe 4 units 3 times a day of rapid acting and 5 or 6 units of basal at night. If patient doesn't agree, then you can try premixed. A good option would be degludec aspart. And if patient is not able to tolerate even that, then only basal insulin. Maybe degludec or glargine U300, 5 to 10 units a day. You can start SGLT2 inhibitor if patient is a bit on the obese side or is overweight. If patient is catabolic, cachexic, thin, do not start SGLT2 inhibitor. DPP4 inhibitor can be given, but if patient has repeated episodes of pancreatitis, then DPP4 inhibitor will be contraindicated. We should avoid it. In pregnancy, we should avoid DPP4 inhibitor at all cost. HB1C is 14. Counsel the patient that we will try our best, but there may be issues. So be in close touch with your gynecologist to rule out congenital anomalies. And we can give insulin if basal bolus insulin at 14%. If a tablet is required, it will be metformin. Dr. A.K. Sharma says a different duration of different comorbidities. Yes, you have to take the history, and depending upon the history of comorbidities and the duration, You decide how aggressive to be. If patient has had nephropathy, neuropathy for 10 years, he has already shown 10 doctors in the past, and he is unsatisfied, chances are minimal that he will be satisfied with me or with you. So you just go slow, don't be aggressive. Chances of hypoglycemia will also be high, so at least don't harm the patient, be slow. If, however, patient has sudden onset comorbidity, whether acute like infection or whether chronic like vascular, if it has just started suddenly, then we should be more aggressive and we should try to bring the glucose down to normal as soon as possible. Dr. Hitesh Vora asks about vitamin B12, oral, sublingual, and injectable. So, in pernicious anemia, injectable vitamin B12 is the drug of choice, is the preparation of choice. I try sublingual because that also bypasses the oral route. So, in pernicious anemia, you have to give sublingual or injectable. Sublingual is easier to use in our OPDs. If patient doesn't have pernicious anemia, you can give oral B12 as well. But sublingual is relatively cheaper, and in my experience, I find it is more effective. So this helps patients more. Dr. Gangadhar Rath shares an interesting clinical case. An interesting clinical case. 50 years person with diabetes, 3 times regular insulin, 120 units a day, and glargine 30 units at night. Total 150 units. So there can be multiple reasons, Dr. Gangadhar. First of all, the simple ones: is patient actually taking insulin or not? Is patient taking insulin in the right manner? Maybe patient has lipohypertrophy and is injecting there. So these are the simple things we should look. Then diet and exercise. Stress management. Is patient able to sleep properly? If patient has obstructive sleep apnea or insomnia, sugars will not be controlled. Then what tablets are going on along with this? Maybe you can add metformin. If you really need, you can add pioglitazone, but GLP-1RA and SGLT2 inhibitor will be safer to add. I'm assuming that renal and hepatic functions are normal. Change the insulin also. From regular, you can shift to analog, and from glargine, you can shift to degludec. Sometimes we can give 5 injections a day, 3 injections of bolus, and 2 injections of basal at 12 hours apart. So maybe we might want to change this 150 units to 100 units total, because certainly over treatment is going on. So maybe initially I would give total of 100 units, maybe 40 units of degludec at night, or 40 units of glargine U300 at night, or 20 units of insulatard NPH, or glargine U100 twice a day. 20 units twice a day of intermediate acting, or 40 units at night. So that's 40. Now rest is 60, that I will give 20 units of rapid acting analog. Along with this, I will add metformin, SGLT2 inhibitor, and if possible, GLP-1RA. If GLP-1RA patient cannot afford, then maybe I will add gliptin. Along with this, I will ensure that the insulin technique is correct, and I will screen for infections. Commonest is urinary tract infection and genital tract infection. I will also screen for psychological, psychosocial health. Many times, a tablet like clonazepam or alprazolam given at night will do wonders for glucose control. If you don't want to do that, then you can also try prochlorperazine. The brand name is Stemitil. And many times, what you will see is that focus on sleep, focus on mental health. This will give you good dividends. Another tablet that you can use for good glucose control is lemborexant. Lemborexant is a recently introduced treatment for insomnia. It helps in controlling sleep, and it also makes the patient wake up very fresh. So you can try that lemborexant. You can give it along with clonazepam or separately. Dr. Hiteshwara talks about vitamin B12 dosage, 1500 microgram OD for 10 days, more than enough, followed by 500 to continue for long. We can use less than that. You can use a normal vitamin B preparation orally, which has much less, and maybe you can give sublingual 1500 microgram once a week for few weeks to begin with, and then once a month. So sublingual 1500 micrograms once a week for few weeks, and then once a month. Dr. Rath raises a very tough question. Vildagliptin SR formulation once a day, 100, is it equivalent to vildagliptin 50 twice a day? So according to the manufacturers, yes. but there is actually no published data, Dr. Saab. So in practice, I have not been using vildagliptin SR100 because when the initial trials were done about 15 years ago, at that time it was said that 100 milligram OD is associated with more hepatotoxicity than 50 milligram twice a day. So I continue to stick to the old-fashioned 50 milligram twice a day. What is the cutoff glucose level to advise patient only on lifestyle and diet control? HB1C below 7.5 will be a good idea for that, but you have to revise your decision after 6 or 12 weeks. Dr. Sanjay Shiora says starting anti-diabetic drug, usually metformin Daxab, along with one more, with maybe a gliptin or low-dose sulfonylurea. Dr. Shukla sir, if you allow diabetic foot, we can take as a separate topic later on in this series. And if Dr. Desai's Q risk is 55.7 at age 54, then nothing to be done, Daxab. Just sit back and relax. Dr. DG Parmar shares a case of a lady 29 years old with TSH of 6 for the past 5 years. BMI is 19 and she is asymptomatic, but she has air fall. T3, T4 is normal. So, Dr. Parmar, we should do thyroid antibodies, anti-TG, anti-TPO. If the antibodies are positive, then we must treat. If the antibodies are negative, we can hold on. Another thing is obstetric history. If family is complete, then you can relax. If family is not complete, then we must get these antibodies done. And we must try to keep the TSH below 2.5. For hair fall, focus on micronutrient adequacy, iron, zinc, vitamins. Dr. Sanjay shares another case of a 25-year-old lady with gestational diabetes. She's on metformin twice a day, 850 milligram, but she lost 10 kg. Okay, that's good. And glucose levels is controlled. So, yes, diabetes is not reversible, but it can go into remission. So, in this lady, she may have gone into diabetes remission. How will we diagnose diabetes remission? If our HbA1c remains less than 6.5 or less than 7 for at least 6 months, how will we predict whether someone can go into diabetes remission? ABCDE criteria. A for age, so this lady is young, that's good. B for body mass index. If body mass index is high and she is willing to lose weight, so that also seems possible. C for C-peptide. If pancreatic function is normal, it seems normal here. And D for duration of diabetes, if duration of diabetes is short. E is for energy enthusiasm of the patient and our engagement with the patient. So I think Dr. Sanjay Shiura has done a great job, and 3 cheers to you, sir, for having got this patient into remission. We have more comments as well, and warm greetings to Dr. Yogesh Oplenchwar and Dr. VK Goyal. Thank you for joining us, sir. And also to Ratna Kumar Patnaik Jagumantri ji, good evening and thanks for being with us. So I look forward to being with you again every week. For me, this is a great uh, occasion, a great opportunity for me to connect with everybody. And Dr. Virendra Shukla, your point on diabetic foot is well taken. We will cover that sometime during this year. Thank you. And I'd like to hand over the stage again to Team FDC to take this forward.
Thank you very much, sir. Once again, sir, it was a wonderful day because first half of the session you took us to the most important part of the knowledge sharing, where you discussed about the decision cycle, which is obviously the patient centric. And the second most, which I like personally, was the timing and the appropriation of the test. Definitely, this will help the patients, especially the poor. And at the end of the session, you always do, because of that, we get always you on the every Sunday night, is that all the questions which all our viewers, doctors feel at the end of the week have at least the chance to consult with Dr. Sanjay Kalra at the top of the pyramid. So that's why it is such a special that every Sunday we spend the day with all the doctors and you. And this is with this, I thank you, sir, and Jai Hind. See you next month, next Sunday, sir, at 9 p.m.
Jai
Good
Hind.
night.